Thank you, Swati, for including me to your instruction course. Uh, so basically, the question is in the glaucoma diagnosis, is the disc glaucomatous? I mean, this question actually arises every time you look at the glaucoma patient. You will look at the optic disc, and the first question comes to your mind is this glaucoma or not? And that's a very relevant and the most important clinical question actually when we are dealing with glaucoma patients. So we'll be kind of a, it's not moving. Can you move the slide? Okay, so the optic disc evaluation is very important from glaucoma diagnosis point of view, and this is very critical, and very often is the first site, to detect glaucoma. If you look at all the patients who have been detected glaucoma, I think 2/3 of them get picked up or detected because someone looked at the optic nerve head. And if you're depending only on intraocular pressure, one reading, you'll miss 2/3 of them. So diagnostic rate is only about 30%, and if you're doing repeated IOPs, then also it will go up to about 50% and not more than that. So IOP is not a good way to detect glaucoma. Optic disc evaluation is a better way to detect glaucoma. That's number one. So is this disc glaucomatous? So the question remains. So this is a patient coming to you, 45-year-old male patient, and what do you think, audience? So how many of you think that this is glaucoma? Raise your hands. And how many of you think this is not glaucoma? Okay, so some are for glaucoma, others for not glaucoma. Remaining are kind of a doubtful, right? And this happens many times because it's not always that you can make up your mind in the first go. And if that happens, then how do we deal with that situation? So that's what I think we are basically going to discuss here. So if you're not able to make up your mind, then the best thing to do is to kind of assign some kind of probability. So, okay, this is the disc. What is the probability of it as being glaucomatous? Is very low or very high? So on the right side of the spectrum, the two ends of the spectrum are easy to identify. So if it's a normal disc, you could easily say, okay, this is normal. And if it's obviously got glaucomatous, it's again easy to say, okay, this is glaucomatous. But in between, if there's like the discs I showed you, they're somewhere in between. And those discs, clinical, we call them glaucoma suspects. But saying them glaucoma suspect is not enough because this doesn't give you what to do, because in between there are many varieties of the discs are there and which could be glaucoma suspects. So idea is basically to identify glaucoma as early as possible. So our strategy would be that if you have a glaucoma suspect, try to dissect that further. So give a little more probability to that, or split that probability a little more. Is it likely glaucoma, or it is possible glaucoma, or it's unlikely glaucoma? Now, if a glaucoma suspect, you can split in these categories. This will help you make a decision. So if you think, okay, the disc is not exactly normal, but it's unlikely to be glaucoma, so that means you will not do anything to that patient. You'll just observe or tell him, you won't treat or investigate. But if your impression is probability is like possible glaucoma or likely glaucoma, if it's a likely glaucoma, you can straightforward, go with an investigation and maybe even start treatment. And if it's a possible glaucoma, you will at least investigate the patient. So this kind of risk stratification, the probability assignment to a given disc would help you take a clinical decision that what is the next step that you would like to do. There are many ways of looking at the optic nerve head, and you have all read in your books. There are classical signs given by Amle, that there are 7-8 discs of, features are there, shape, size, cup, and so on. There are some other methods of looking at, like you have slide, SINGH slide, or force series of slide where they talk about the 5 R's of glaucoma, and you have a disc damage likelihood score, which gives a little more objective way of looking at the disc cup and neuroretinal rim. My approach is a little bit simple. What I do is I look at what is important. So a lot of these disc signs feature in the disc, they are important in a way, but they are not the most important. And many of them are actually just there because glaucoma happened or did not happen, but those things are there. Like blood vessels change in a certain way. So change in the blood vessel configuration doesn't say that is glaucoma. It just reflects effect of glaucoma on the disc vessels, and that actually gives you some kind of indirectly a clue that this patient might be having glaucoma. So those are just clues. So what is important in the optic nerve head basically is there are only two things. There's only one thing basically, that's a neural tissue. So what we are concerned in glaucoma is neural tissue, because glaucoma is an optic neuropathy, and you see loss of neural tissue in glaucoma patients. So focus on the neural tissue, and the neural tissue in eye is neuroretinal rim and the nerve fiber layer. So these are the two elements which are neural tissues. So mentally you need to dissect the neural rim and the nerve fiber layer. So if you can mentally dissect, so if you look at the eye for glaucoma, mentally you dissect, where is the neural rim tissue. And once you have isolated the rim tissue mentally, visually, you have to ask a couple of questions. So is the amount adequate? Is there a neural tissue that you can identify and is good enough or enough, which is normally you would see? Is it rightly distributed? There's a certain kind of proper distribution in the optic nerve at, of the neural tissue is for following the proper distribution. And is it healthy, or does it look sick, or any evidence that is a disease in neural rim tissue? So rim tissue may be there, but it may not be healthy. So you will have to basically ask these three questions to yourself, and then look at the nerve fiber layer, and is it there or there is any loss. So if the answer is all, if the is adequate, if the answer is yes, then there's no glaucoma. Basically you are dealing with this eye is normal. But if answer to any of this is no, then you have to consider the probability, whether it's a strongly in favor of glaucoma or somewhere in between. The problem is that there's a lot of normal variability in glaucoma, and you can be, there'll be a lot of confounders. So that's why glaucoma diagnosis doesn't come that easy, because there are certain confounders. Now in these three discs, they all look very different. So this one looks very different, this one is different, this one is different. So which one you think is glaucomatous? So again, the important thing here to consider is defining the neural rim tissue. So first thing is to define the tissue. So here you can define the tissue. On temporal side it's a little hard, but you can see some tissue there. You can very easily define the tissue. So once you have defined the neuroretinal rim, now there's no confusion here. Now you can see there's a good amount of rim tissue is present, all eyes is properly distributed, and there's no evidence of any disease. So all these eyes are normal, right? So other thing is how that is distributed, and ISNT rule you are all familiar with, so I'll not spend much time on this, but there's a kind of inferior, superior, nasal and temporal, so that's how it is distributed. So look at the optic nerve head now from the distribution point of view. Now these are the three discs. What do you think about the distribution and the amount of tissue here? So you can see the neuroretinal rim is there, there's good amount is there, a lot of rim tissue is there. So there's a good amount of rim tissue that you can actually identify, but is it distributed properly? So if you, again, the exercise is to define the limits. So the key skills that you need to diagnose glaucoma is two only. You should be able to define the inner edge of the scleral canal, and you should be able to define the inner limit of the neural rim. So if you can do these things reliably, then your glaucoma diagnosis becomes easier. So you can see, if you define them here, you can see the rim tissue is actually missing at certain areas. So that gives you a clue that this is a problem. There's a loss of rim tissue basically, and loss of rim tissue would mean that there's a neuropathy there. And then again, you could have confounders here also, because if the eye is normal, then this ISNT rule is applicable. But if the eye the disc is tilted, or if it is rotated, then ISNT rule may not be applicable. So that you have to keep in mind. And other problem comes when as you can see, the inferior rim is actually behaving like a temporal rim here. But this is because of the disc tilt. And then of course you have to look at if the cup is shallow or deep. So if the cup is very shallow, then again you might have a little difficulty in defining the inner limit of the rim tissue, and there again you can make a mistake. Is the neural tissue healthy? So I think again, obviously you can see this is a pale disc, so it may not be glaucoma, but this is not a healthy disc. So but this is rim tissue is there. So here again you can see there's something is not right with the tissue here, and you also have some atrophy in the peripapillary area. So there's a rim change there, and so this is again probably a resolving hemorrhage as well. There's a disc hemorrhage clearly here, so there's a sign of that this is not healthy. Sometimes you can have extensive peripapillary atrophy, which again suggests that something is going on the posterior segment, but it is not always glaucoma. So if you this is interesting that if there's a lot of peripapillary atrophy here, but if you define the rim tissue here, you can see the rim is very very well defined, and there's no problem with the rim itself. So this is again a healthy eye. So this is basically how you would be looking at the optic nerves. Can you just give me a little more slides? So I'll make it a little quickly. Yeah. All right. So and the third thing I said is the neural, the nerve fiber layer, which you have to see. So if you see a nerve fiber layer like this, again, this indicate that there's a problem with the neural tissue there. So there's a loss of tissue there, and this is how this would look like. So you can see that the rim area is very well defined. There's a little thinning eye-center rule is not followed here, but and also there's a tissue. So if you see this kind of a picture, there's no doubt that this eye has glaucoma. So glaucoma or not? So what is your question? So is this has glaucoma? So obviously all the parameters we have spoken are actually normal here. So this is not glaucoma. So but again you have to take a final call whether that this is glaucomatous or not. So this is glaucoma or not is the same eye. So if you can't define what is the probability, so probability is unlikely. There is little change in this here, which might be tempted to say, oh, there's a little notch there, but there's no other evidence in the nerve fiber or anywhere else to say that it's glaucoma. So there's a little suspicion, but it's not really enough to say this is glaucoma. So you can probably say it's unlikely glaucoma. So if it's unlikely glaucoma, you will just follow up this patient, after 1 year or so. So this is glaucoma or not? Again, the question, what would you say? Where will you place it? Normal, unlikely, possible, likely. So again, if you define the disc margins, we did the OCT, we did HRT, everything is normal. Family history of glaucoma is there. Now, based on this, there's a possibility of glaucoma because there's a little change over there. And we did the visual field because we was considering the possible glaucoma. So we did the visual field, a little change there. And when you put everything together, the diagnosis actually moves towards likely glaucoma because now you have a little thinning of the nerve fiber rim there. There's a little bit of thinning of the nerve fiber layer here and here as well. So once you look at more carefully, the signs, they actually start coming out. And this is a likely patient of glaucoma. This quickly is glaucoma or not. So again, there's a hemorrhage there. If you notice that there's a nerve fiber defect, and there's you don't even need a visual field or any other investigation to say that this is a glaucoma patient. So this is almost certainly a glaucoma patient. Glaucoma or not glaucoma? So again, you can see there's a bit of thinning there. There's a hemorrhage there, thinning there, hemorrhage, and there's a nerve fiber thinning there. So if you can see these signs, definitely you have this is a likely glaucoma patients again. So this is again a normal glaucoma patient. So this is normal. So that way you can actually ratify or so again there's a little change but not enough basically. So it's unlikely glaucoma patients. On the other hand, this eye, what do you think about this eye? So good neural retinal rim, there's a little bit of you can see there's a little bit of notch there, not very clear, but there is something there, and this nerve fiber layer looks a little thinner. That it's not coming as good in the projection, but still you can make out that a little bit of darkening is happening there. And if you draw the limits of the disc and the neural rim, it stands out, and it stands out there, and this becomes likely glaucoma. And when you do visual field for this patient, there's a there's a nerve, there's a visual field defect as well. So I think these are very subtle signs, but if you look at your disc more carefully, you can actually pick up, and you can pick up glaucoma before it appears on the OCT or before it even appears in the visual fields. So I think that is the message. So glaucoma diagnosis is a clinical skill. Disc evaluation is fundamental, is very important, and often this is the first place to detect a glaucoma.